Qua vote. I'm happy to be back here with the fourth session of this pesticide poisoning program. Actually, it's not that much poisoning, pesticide poisoning today, a little bit upon your request from last week. But first, I would like to hand over to Thea for a short explanation of what we're planning.
Yes, if you could please go over to the next slide.
Yeah. Oh, okay.
Okay, perfect. So yes, hello everyone. Today is the last session of our medical training module, and we would really appreciate your feedback on the last, on this whole training. So at the end, we will have a Mentimeter live poll. And for that, we will be showing the slide again at the end. But for that, you will have to log in. You can either do that by scanning the QR code with your phone or by going to, menti.com. Nice, there we are back, perfect. To menti.com and then enter the code shown below, or by clicking on the link, which I will be posting in the comment section in a bit. This will be at the end, so after the training, and we'll be showing that. We will be waiting again until everyone was able to connect to Mentimeter, and then we will have the live poll session. Okay, then back to Dr. Wolf.
Okay, thank you. So today we are at day 4. And we have quite a bit of a program. You asked for some words on Amitraz, which I have prepared last week. Then we would like to talk about our CAIRnew database and ask for your kind support. And then there are 2 topics which are not really pesticide related, but from all countries we talked to so far, I have been asked to include them. These topics are heat stroke or heat stress, and snake bites, which also are significant problems, obviously, in tropical countries. So today it's without video of myself, obviously, but that's not the problem. More of a problem is that the presentation does not move. Bitte? Sorry for that. I'll stop it again and start again. So first things first, upon your request from session 3, let's call it active ingredients part 3, though it's only a single one, like the pyrethroids in session 2. And again, the disclaimer, the following refers to acute intoxications and their treatment only, not the chronic exposures and their potential effects. Plus, we only can cover active ingredients that are used in bioproducts registered in Kenya, and those like Amitraz here that have become generic, like OPs, carbamates, Amitraz. So 2 publications as literature. Amitraz is an insecticide and acaricide. The main use is in veterinary medicine against ectoparasites like mites or biting insects, but it's also used in fruit crops. And well, there are many poisonings in West Kenya, I learned last week, also in other regions. This does not really show up in literature. There are a few publications from Africa, more so from India. The LD50 of Amitraz, I don't know why it's moving by itself now, sorry. Amitraz has an LD50 of 650 milligram per kilogram, which makes it a class 2 pesticide. And it has one main and some further modes of action: stimulation of alpha-2 adrenergic receptors, more of exactly A2 in brain and alpha-1 and alpha-2 in the periphery. It also inhibits monoamine oxidase and prostaglandin E2 synthesis. The good thing about Amitraz is that it has a short elimination half-life of 4 hours. So after 8 hours, only 20% of the dose ingested are still in the organism. The bad thing is that obviously until today, many formulations contain Amitraz at 12.5% in xylene as a solvent. And xylene is actually a toxic solvent, which in itself will cause coma and CNS depression. So I'm not sure whether all the descriptions of CNS depression in the literature are really due to the 12.5% Amitraz or to the 87.5% xylene. In any case, toxicity starts at an Amitraz dose of about 3.5 gram per kilogram. All in all, close to 400 cases have been reported over the years. The fatality rate is quite low, 1.9%. Signs and symptoms are CNS depression from drowsiness to coma, lasting not more than 48 hours. Even if the patient needed mechanical ventilation, he woke or she woke up after 2 days. The respiratory depression is common. Seizures, convulsions are rare but can occur. It's interesting that at low doses or early in poisoning, there is a meiosis, so pinpoint pupils. At high doses or in the course of a poisoning after meiosis, there will be mydriasis, so very wide pupils. Bradycardia, hypotension, hypothermia can be caused. It's quite typical for Amitraz poisoning to see an elevated blood glucose level, a hyperglycemia. So not seeing this makes the diagnosis of Amitraz poisoning a little bit uncertain. Liver transaminases are slightly elevated. I doubt that this is the Amitraz like the CNS depression. This may very well be from the xylene. Well, pinpoint pupils, doesn't that remind us of something? Yes, indeed. Organophosphates and carbamates. So the literature is full of cases where there was an initial treatment with atropine, even with oximes for Amitraz. Both is not indicated. To tell the difference, you don't have increased secretions. I said last week on organophosphate and carbamate poisoning, everything flows. So in Amitraz, you can say nothing flows. The mouth is dry, there is no sweating, there is no diarrhea. So this is a clear difference. And there are also not the typical fibrillations, which I had described as small worms crawling under the skin in different directions. And this does not occur with Amitraz. So if you look closely at the patient, you can, I would even say easily see that it's not an OP or carbamate poisoning. The symptoms appear relatively fast, 30 minutes to 3 hours, but 5 minutes to 6 hours have been reported in single cases, but obviously these are outliers. What do we see? Again, we see initially or at low doses all the time the meiosis, at high doses or later in the course of poisoning, mydriasis. Hypothermia, this is the only effect promoted by the prostaglandin inhibition. Central nervous depression from drowsiness to coma. Respiratory depression to respiratory arrest, and convulsions are possible. Regarding heart and circulation, bradycardia and hypotension are quite typical, and nausea, vomiting, abdominal pain. Distended abdomen is possible, but there will be no diarrhea, which is a difference to carbamates and organophosphates. So what do we do? Skin and eye decontamination as always. You remember that I said no induced vomiting if solvents have been ingested. And here you have a real lot of xylene ingested. There are other products that may contain tetrachloroethylene or aromatic petroleum distillates, which are no better, but generally it's xylene. So induced vomiting clearly is not recommended. Gastric lavage is generally also not recommended, only if life-threatening amounts, which means more than 12 gram active ingredient, Amitraz, not the whole formulation, but 12 gram of Amitraz, have been ingested, and intubation is required because of the solvents. Application of activated charcoal should be considered. Cathartics do not play a role here or, as said, anywhere else. There is no antidote. Treatment must be supportive. This can include even atropine, but only against the bradycardia, not against the actual poisoning. So you would give carefully normal doses of atropine, starting with 0.5 milligram or 1 milligram, until you see that the pupils widen and the bradycardia is being reversed. In many cases, obviously, this is not sufficient, so newer literature describes the necessity of dopamine infusion to reverse bradycardia and hypotension. While in case of respiratory failure, which will be central in this case, mechanical ventilation is required, but is very rarely needed for more than 48 hours, because as said, then practically all Amitraz is out of the organism and the patient wakes up. Animal tests have shown that prazosin, an antihypertension medication, and yohimbine are effective in animal tests. There has been one single use of yohimbine at 0.12 milligram per kilogram in a child, but well, this is just one case, and I would not want to generalize this. So you can keep in mind yohimbine has been effective in animals and in the single human case where it has been used. The seizures and convulsions, which actually are rare, can always, according to literature, be treated with diazepam or maybe lorazepam. It seems that phenobarbital or even propofol are not required. Oh, okay. So these are the two publications again, one from India from 2016 and the other one from Sri Lanka from 2017. This brings us to what we did last week. Are there any pressing questions on Amitraz poisoning? And besides that, I would also open up the opportunity again to ask questions about the active ingredients we have addressed last week. Take a look at the F&A, so nothing yet. No questions? But you all can hear me, it's so silent.
Can hear you, but I don't see it.
Well, toxicity the question is, when is activated charcoal recommended? I said the toxic effect start at a dose of 3.57 gram per kilogram. So below that dose, I would not give charcoal. Above that, yes. What's the role of giving fluids, Mileva Mule? Do you mean this orally or intravenously? Or let me address both. Orally, I would refrain from giving fluids because you will push by this the toxic substance, the poison, from the stomach into the intestines, and there is where the absorption is happening. Intravenously, well, if you have a patient with bradycardia and hypotonia, you will also use saline solutions or ringer lactate, something like that, to stabilize the blood pressure, and as a carrier probably for the dopamine. Maximum dose of activated charcoals in adults is 100 gram, and in children it's 50 gram. As a slurry, not as tablets. like my mother used to give me when I had diarrhea as a child. They are not effective. That's not enough. So you really need 50 to 100 gram. 50 in children, 100 in adults. Yeah, the clinical signs. The difference is in principle, the meiosis and the bradycardia do not let you distinguish between amitraz and organophosphates or carbamates. But as I said, with organophosphates and carbamates, everything flows. The saliva is flowing, the patient is sweating, there is diarrhea, there is accumulation of fluid in the lungs. All this flowing is not happening in amitraz poisoning, so the patient will be dry. In some cases, they complain when they arrive in hospital even about a dry mouth. So this nothing flows aspect clearly rules out organophosphates and carbamates. Moment. There. The amitraz poisonings are not common in about 30 years, about 400 cases. There were 300 until 2013, and a rough rule of thumb calculation brought it up to close to 400. Fatality rate is 1.9%. And Grace, this does not refer to amitraz, I suppose. For occupational health practitioners, what would you use as a baseline when the employee did not have a baseline test pre-exposure, given that the baseline varies for different people? Yeah, that may be a problem. You should do a baseline, preferably of the acetylcholinesterase in red blood cells, but this is not really possible because the reagent is missing. So you will have to do the butyrylcholinesterase, and this does not really require the 3 month. The 3 months are important, and for the acetylcholinesterase, the butyrylcholinesterase you can do, well, more or less any time, because, well, from albumin in blood, the binding is not as long. It will be out in like 2 weeks or so. So let's say 2 or 3 weeks without exposure. Then you can check the butyrylcholinesterase in serum. But please remember, this is prone to alterations by medications and by alcohol. So normal liver diseases will change the butyrylcholinesterase. It's not as reliable, but at the moment, that's the only thing we have. And then you have a baseline, and when that drops by 30%, plus you have the typical symptom, this everything flows, and the muscles are contracting as fibrillations, then you have the full picture, and then you will give antidotes. Alpha 1 and 2 agonist in the periphery. Why explain bradycardia and hypotension? I'm also not quite clear about this, especially because the patients in the course of the, in the course of the poisoning may well develop tachycardia even without dopamine and atropine, but I have no real explanation for this, but in an overview, in a meta-analysis of reports, they saw bradycardia and hypotension for most patients. And Grace, you added to your question, organophosphate exposure and acetylcholinesterase test. If you can do it, you will need 3 months non-exposure time, because, well, you analyze the enzyme in erythrocytes, in red blood cells, and their lifespan is 120 days. So if you have it in the cells from an exposure, after 3 months, it will be gone. This unfortunately cannot be shortened. The next question by Kirsch. Okay, so just an observation, okay. Dr. Kamau, intubation prior to respiratory distress. As not all patients get respiratory distress, I would wait until there are the first signs of respiratory failure. Beginning respiratory failure would be the indication for intubation. Gastric lavage, yes, you can do that, but only if the airways are really secure. You're dealing with a lot of xylene in the stomach, and if the patient starts to vomit during the gastric lavage, which happens not really rarely, then there is a huge risk of aspiration of an organic solvent, xylene, into the lung, and this will destroy the lung tissue. So you clearly don't want this. If you can make sure that the patient is correctly intubated and the tubus is blocked, then you can do a gastric lavage. Simon, as far as I know, you will be able to access the presentations and can see the literature for all of the active ingredients that I have used. So it shouldn't be a problem to access it from there. I hope this is sufficient. Okay. No more questions? Okay, then we can continue. Thank you very much. Yes, we could continue if I could make it work again. Bitte? Da ist bei mir nichts. Ach, da. Okay. Well, I said we would like to present the CAIRnew database that we have for our company here, for Bayer, so it's not general. CAIR means complaint and incident reporting. It's a tool for reinforcing external incident management with an adequate software tool. It's our worldwide software solution for reporting, managing, and analyzing external incidents, including poisonings, also environmental incidents, transport incidents, damaged packagings, everything. But it also has the function of addressing medical incidents with our products. Within the company, various business segments can use this database to enter cases in one central system to alert colleagues worldwide, and in particular here in the center in Monheim, Germany. We can manage and document cases and steer the investigation by involving other people, other specialities, sharing infos, coordinating tasks and workflows, identify issues, so a group of similar incidents, for instance, and coordinating corrective actions. We can view and analyze data per topic. So if I want to know, have there been cases with Amitraz? Long ago in the 90s, it was a product of a predecessor company of Bayer. So should I get the idea, I want to know something about old Amitraz cases, I can look for the active ingredients, the country, and identify trends. What I always said in occupational medicine, if we have one case of symptoms, whatever, elevated liver enzymes in, let's say, Kenya, what do we think? Yeah, that's okay. One case can happen with the many people that are examined in occupational medicine. Sorry. But what if we have one case in Korea, two in the United States, one in Switzerland, one in Thailand, one in Paraguay? Then we must be alert because there may be a problem. And this database is to make us able to identify such issues. We are following the FAO/WHO code, which stipulates monitoring how products are used. All internal adverse incidents, as I said, not only medical and veterinary. but we go further because sometimes there seems to be a gap between the communication done by NGOs and the media and what our CAIRnew database actually shows. We take the communications by NGOs and media seriously and try to have an overview of these topics. If there is seemingly a gap, we have to check why is that. This can be different interpretations of what is happening on the outside, but it can also be that our infrastructure and resources are still not sufficient. So we check out the CAIRnew database. If there are differences between such reports and our experiences or our knowledge, we have to recheck our information and our reporting channels. New cases can be added via a specific PDF form, which does not absolutely require to have access to the system. Not only internals, but also externals can use the PDF to enter a case, but it's a specific PDF and it goes directly in the system, and the system, CAIRnew system, alerts all the people who are concerned by this topic. For instance, if it's medical, I used to get all the information on medical incidents, and I hope I still will now, even though I'm not fully with Bayer currently. Externals should send a request to Margot Burgards, our colleague who is heading the CAIRnew program. Access can be given to individual emails or to an entire domain like KNH, for instance. External addresses without access cannot really submit the PDF. Plus, you need the PDF, so it must be sent to you after you showed interest. So again, in a nutshell, what do we do with CAIRnew? We collect poisoning incidents and others with Bayer pesticide products, not pharmaceuticals, and only Bayer, not generics, not other companies, on a global basis. We evaluate the incidents with medical support and veterinary support if needed, assessment, for instance, of safe use, PPE used, the incident type and frequency to see clusters appearing, potential hazards and risks. And if we identify room for improvement, we can increase safe use trainings, rephrase labels, improve technical measures, or improve medical support. We do this in some countries already in close cooperation with poison control centers, which can easily send their cases by XML directly again into the database. The target for us is, because the poison control centers is, as the name says, centers, so they're in large cities. So we have now the idea that it would be good to involve physicians in rural areas who will have first-hand knowledge of incidents. As said, the notification is simple: email, PDF, XML, always anonymized, no names, please, and no other data that make it possible to identify a patient. And usually they go automatically into the system. On this, we plan to come back to you, to this group in Kenya, but you're welcome to indicate your interest already now. Any questions on the CAIRnew database? F&A. Okay, nothing new. Okay. Bitte? Yeah, case fatality is 1.9%. Complications are also rare. Most Amitraz cases go without problems. Okay, this concludes the pesticide part. And we now would come to the chapter we have called When Nature Strikes. As I said, we have been asked, and well, in the end, I have been asked to prepare something On heat stroke, this came mainly from India, but also Kenya was interested in this, and obviously snake bites are an issue all over the tropics, which I can easily understand. So let's start with heat stroke. Heat stroke is the severest form of heat-related diseases. Others are heat stress. They're due to an imbalance in the thermal setting of the organism, of the human body. Sweating, as you know, is the cooling mechanism of the body, but it does not work well in humid air. So I personally find it very difficult to be in Thailand during monsoon. It's still awfully hot, but you can't sweat because the humidity in air is about 100%. And well, it's unbearably uncomfortable then. An example is I'm very well in sweating in heat. My wife is not, and she always complains about circulation problems and is very unhappy with heat. I don't care that much as long as I'm not during monsoon in Thailand. The problem is that the body temperature can rise to dangerous levels. This can end with shock, with brain damage, and with death. Children and senior people are more at risk. Both tend not to drink enough. Well, actually, most people tend not to drink enough, but well, in these age groups, the problem is even more severe. Heat stroke, as the severe condition, is usually caused by prolonged sun exposure, imbalance in the thermosetting system, and dehydration due to excessive sweating and insufficient fluid intake. There are conditions that may contribute to heat stroke. These are thyroid disorders, low blood sugar, alcohol intake, and intake of psychopharmaca, antidepressants, and stimulants. It causes, as we will see, physical signs and symptoms, so it can be easily noticed. If at all possible, if the symptoms go in the direction of heat stroke, a doctor should be seen as soon as ever possible. Heat exhaustion will have the symptoms of weakness and fatigue, nausea and vomiting, dizziness, headache, low blood pressure, and scarce sweating because the thermoregulation is impaired. The sweating capability is reached, and so sweating becomes scarce. Muscle cramps can occur because you lose electrolytes when sweating before. The symptoms get much worse with a severe sunstroke or a heat stroke. High body temperature, which can reach 40 degrees Celsius or 104 Fahrenheit and more. The skin turns red, dry, and hot, so no sweating at all. Increased heartbeat, rapid pulse rate, excessive thirst, difficulty in breathing, restlessness, agitation, up to confusion. In very severe cases, seizures and convulsions are possible, unconsciousness and coma. So there is actually really a risk of death from heat stroke. Well, to whom am I talking? I'm sure you're much more used to heat than we are here in Germany, and you will know in principle much better than me what to do. The following is advisable. Follow the recommendations and weather reports. Most people have smartphones today, and I learned that farmers usually have one and look at the weather reports. There also will probably supportive advice from local, regional, country governments. Obviously, like in India, it's a good idea to work during cooler hours in the field. So from the early morning until about 10 or 11, and again from 3 or 4 in the afternoon until late evening. You should cover your head. As you see, the worst symptoms come from the head and brain. Wide-brimmed hats are good for that. You should wear light-colored fabrics and light-colored and light fabrics in loose fit to allow the skin to breathe. The photos I've seen from Kenya, from people in the field, tell me you're doing this. Drink sufficient water before going out into the sun and take water with you to the fields. You can also eat fluids. If you eat things like melons, cucumbers, pineapple, oranges, grapes, even spinach, lettuce, and broccoli, you ingest a lot of water. So this will also help. Grilled meat, I would always prefer, but well, it doesn't give you water. The treatment, if there is heat stress, seek shadow, drink water. If available, electrolyte drinks. This does not mean Red Bull, but there are electrolyte drinks that replenish the electrolyte stocks in the body. If you have heat exhaustion with fatigue and the symptoms mentioned before, stay in shadows, loosen the clothing, drink water, maybe wet the clothing so you have a cooling effect by evaporation from the clothing. Wet it frequently and seek medical attention. In case of heat stroke, medical emergency service will be required and the patient should go to hospital. Outer clothing should be removed and the other measures should be continued, like cooling the body with water. An additional advice coming from India, the Indians know a lot about heat, as we saw in the last weeks with the adventurous temperatures there. Drink buttermilk with some salt, not too much salt, even if you feel you want salt, but little salt, but not too much. Do not drink alcoholic beverages. I put in brackets stronger than beer because there is not that much alcohol in beer. Water, however, is always preferable. I'm not suggesting to drink beer, but if you don't have water, you can drink beer. Caffeinated drinks are prohibited. They may increase urination, though this too is under discussion by now, but well, I would stay away from caffeinated drinks. Yeah, and now I would be happy, not for questions on this, but for your advice on how you deal with heat stress. Do you have any suggestions how you counteract heat stress and avoid heat stroke? No?
Dr. Stephens, probably not a question, but probably a comment to put out there. Usually when we think of sunscreen,
Then onwards to a topic that I like myself very much because I'm very fond of snakes and I'm keeping 4 non-poisonous snakes at home. The topic is snake bites. As you see, the main source I used for this presentation is the publication by the government of Kenya, Ministry of Health from 2019, Guidelines for Prevention, Diagnosis and Management of Snakebite Envenoming in Kenya. One word of warning already now. You have, for instance, saw-scaled vipers in Kenya as well as in India. But already in India, the venoms of saw-scaled vipers in, for instance, Tamil Nadu in the south are different to those in the north. And the differences between countries are far too large to use an Indian antidote in Kenya or vice versa. This is being done, I learned, but it's not really a good idea. Geht irgendwie gar nicht mehr an, das ist komisch. So this is an overview on, in principle, it's neglected tropical diseases. One of them is snakebite. The infections and parasites and worms are not that interesting in this context. We're looking at the disability adjusted life years and the costs. So the disability adjusted life years are from snakebite like 8.5 There are more than 30,000 fatalities in Africa. I don't have real numbers for Kenya. And about 8,000 limb, arm or leg amputations per year. Plus, as you can see with this child with the huge scar on the left arm, there may be psychological disabilities. The costs for the disability adjusted life years are in a range of $40 in each case. So this is a quite a costly affair, the snakebite problem. The incidence of snakebite, obviously, but the numbers are more than 20 years old, and there are no figures on overall country incidences or mortality for Kenya. In different regions 25 years ago, the incidence was 1.5 to a full 67.9 per 100,000 people a year. You have three large groups seeing it from the perspective of the venom in Kenya. You have neurotoxic poisonings, which will cause muscle paralysis. We'll come a bit more closely to this later. This is caused by the mambas, the true cobras, and the tree cobras. Then you have hemotoxic poisoning, envenoming. This means unstoppable bleeding. This is largely by back-fanged snakes, but to some degree also by saw-scaled vipers. And you have cytotoxic venom, which causes tissue destruction, like on the arm of the child in the photo before. This is from spitting cobras, large adders, and vipers. There are antivenoms for these species, but we'll come to the antivenom issues later. By far the most and the most dangerous bites are from puff adders. There are more venomous snakes for which there is not an antivenom, so treatment can only be symptomatically, but their bites are rarely critical. So these groups, the mambas, cobras, spitting cobras, large adders, vipers, are the most critical snakes. If we come to the neurotoxic snakes like black and green mamba or cobra, the symptoms of envenoming are in the beginning of the poisoning effects, drooping eyelids, which is called ptosis. You can see, hopefully, that this patient cannot really open his eyes because the lids are, well, like too heavy, and the patients are unable to extrude the tongue. There will be double vision, vomiting, salivation, difficulties with swallowing and breathing. And you can imagine if this paralysis, this is in the beginning causing the drooping eyelids and the inability to extrude the tongue, goes on and becomes worse, respiration will stop. Death can occur rapidly. When I have been going to Namibia in the 90s, information I found then is you have 20 minutes to reach a ventilator after a ventilation machine, breathing ventilator, after a bite of a black mamba. So this can occur, but this will take usually several hours, so there is time to react. Antivenoms are available for these snakes. The cytotoxic snakes, you see here a lady in the bed where the foot had to be taken off, then amputation of the foot. The bites are very painful. There is progressive swelling and blood-tainted fluid is coming out of the wound. Then there is blistering, bruising. There may be a hypovolemic shock because too much liquid goes into the blisters or is leaking out. And then there is irreversible tissue death, which is called necrosis or gangrene, that can develop and may require amputation. Death can occur after initial local symptoms several days later, in rare cases also earlier. The snakes that can do that are spitting cobras. This happens only from a bite, not when they spit into your eyes. From puff adders, they think nobody can see them, so they lie in hiding and do not move away and do not move until you step upon them. It's similar with gaboon and rhinoceros vipers. And then there is this saw-scaled viper. It's relatively small, maximum 85 centimeters. It's aggressive, so it will bite, I wouldn't say for no reason, but at least for no good reason. And the venom is both cyto and hemotoxic. Hemotoxic means profuse and incoagulable bleeding, like in this case from the gum. This is typical for back-faced snakes, back-fanged snakes. That means the fangs are not like with cobras, adders, vipers in the front of the mouth, but in the very back. This means they have to bite, very, very deep into your hand, and usually they need to hit the skin between the fingers to inject venom. But there is no antivenom for tree snake and vine snake, only for boomslang. So there are cases when, well, you have to treat severe bleeding symptomatically. There have been less than 10 deaths in history caused by boomslangs, even less for the others like tree snake and vine snake. The saw-scaled viper I've already mentioned. This is clearly more of a problem than the back-fanged snakes. So, snake bites happen. Where? In compounds. They can happen in farmyards, on fields, in gardens, also in houses. Snakes come into houses looking for prey. If you keep chickens, you will feed them with grains, which will attract rat or mice, and the snakes will come in for the rats and mice. Or they come into houses seeking for water. When do the bites happen? At night, when you get too close or you step on a snake. During daytime, when you're cleaning refuse, they like to hide under waste. When you collect firewood or foliage, when you walk through long grass or underwood. Again, puff adder and gaboon viper are hardly visible between fallen leaves and will not move away. So you have to be careful. And how can you get bitten? By being careless, by not watching your step, by putting your hands in holes, nests, cracks, or devices where snakes may be hiding and resting. So this brings us to the don'ts in snake bites. Do not keep livestock, in particular chickens, in the house. Do not keep food in open containers that are not rat-proof. Do not keep granaries close to the house. Do not let tree branches reach your house, so the snakes can crawl over the tree branches on the roof and into the house. Do not keep rubbish around your house. A piece of cardboard is a wonderful hiding place for a saw-scaled viper. Do not let underwood or long grass grow close to your house. Do not collect firewood at night. And do not walk at night without proper shoes, a walking stick, which you really hit on the ground, and a torch to see where you're going. And do not handle dead or seemingly dead snakes. A snakehead, a sewered snakehead, a snakehead cut off from the body can still bite you and envenom you and inject its venom into your hand if you try to touch it. So never handle a dead, injured, or seemingly dead snake. Also, do not try to chase or kill a snake. Just remember how it looks like. Do not try to cut or suck from the bite. This does not work. Do not apply ice to the bite. And this is a general recommendation in all countries. Do not visit traditional healers. They have no means against snake bites. Black stones, for instance, don't work. A traditional healing attempt will delay adequate treatment. The remedies are ineffective, and relying them actually increases your risk to die. Go to a hospital and get antivenom if needed as quickly as possible. And if needed, must be decided by a doctor. Nevertheless, in case of a bite, remain calm. This is easier said than done, I'm sure. But, well, if you panic, this will make things worse. Remove anything that's tight around your hand, wrist, arm, foot, ankles, leg, or waist, because you must expect quick and significant swelling, and maybe you can't get your wedding ring off anymore, or a bracelet or something. Contact the nearest health workers and try to get to the nearest health facility without exertion. So it's best to be taken there in a car, in the back of a pickup, on a motorcycle, on a bicycle, riding, whatever, without your own exertion. The first aid for snake bites is reassure the victim, move away from the spot where the bite happened so the snake cannot bite again the same person or another person, a helper. As said, remove anything that may constrict swelling limbs. Put patient not on the back but in recovery position and immobilize the bitten limb with a splint or sling. If you have a clear mamba or non-spitting cobra bite, you can use the pressure immobilization technique. I'll come to this in a moment. In case of an attack by a spitting cobra, which incredibly exactly can target your eyes, wash the eyes very thoroughly and see a doctor, and arrange transport to a medical facility quickly, safely, and passively without exertion, as said. Preferably lying in recovery position, but if need be, as a passenger on a motorcycle or a bicycle. In that case, though I'm not very fond of 3 people riding on a bicycle, this may be required here. You have the driver, then you have the snake bite victim, and because he may lose consciousness or get paralyzed, there should be a third passenger behind him to hold him on the motorcycle. Don't do as first aid. Do not attempt mechanical venom instruction, incisions, suction, ligatures, blackstones, burns, or even prophylactic amputation have been described. No, don't do that. Do neither apply chemicals nor ice to the wound. Do not use a tourniquet and stop the blood perfusion of the limb. Do not apply electric shocks. And in this case, do not give caffeinated drinks nor alcohol, also no beer, to the victim. The pressure immobilization technique. Many of you will know how you put a bandage on a twisted ankle. With the same pressure, you first put a bandage on the bite wound, as you see in step 1. Then you start at the foot and put a second bandage as high as you can get, as covering as much of the limb as possible. If you don't have a second bandage, you can use anything else that's available, any fabric. And then you need a third bandage to splint the leg. In the simplest case, you can use a tree branch or a ruler from school to immobilize the limb, and then bring the patient to hospital. As said, this is if you are certain that it was an Egyptian cobra or one of the mambas. It is not suggested for, or it's prohibited even for cytotoxic snakes. So not for the adders and vipers, and not recommended also for the hemotoxic snakes, the back-fanged snakes. But for the others, this is a generally accepted method of immobilizing the limb and slowing the distribution of the venom. The rural health clinic will have to take the history, do a clinical examination. For analgesia, paracetamol, or if needed, tramadol, not aspirin, diclofenac, or ibuprofen, because these will increase the bleeding tendency. Give antivenom if indicated, and as we must say nowadays, and available. In case of paralysis, keep the airways free, give oxygen, transfer the patient to a better equipped hospital as soon as ever possible. So let's assume the patient comes to the district hospital. Same things again. Now analgesia with injection of opioids will be required because the pain will be quite strong. Antivenom if indicated and available again. If there is necrosis, give a tetanus booster, antibiotics, and ask the surgeon whether he thinks a debridement is already required. In case of paralysis, intubate the patient or apply a laryngeal mask. If needed, assisted ventilation, manual with an ambibag or better with a mechanic ventilator. In case of renal failure, apply peritoneal dialysis or forward quickly to a referral hospital. If there is severe bleeding or severe anemia and there is no antidote like vine snake and tree snake, consider blood transfusion. In the referral hospital, antivenom. If needed, advanced surgical management of local necrosis, which can unfortunately mean amputation. In case of renal failure, peritoneal dialysis, hemodialysis, or filtration. And obviously, in case of paralysis, mechanical ventilation with intubation or laryngeal mask. Well, the issue of antivenom in Africa and also in Asia, there is a scarcity, a drought of antivenom since about 2015. There was a huge European antivenom maker who had a very nice antivenom against the 10 most critical poisonous snakes in Africa, not against one, but all of these. But it was not used anymore because the hospitals were buying other cheaper antivenoms, in part even from Asia. And you remember what I said about using an antivenom against the Indian saw-scaled viper for African saw-scaled vipers. As a consequence, the antivenoms may be used at too low doses. The doses are enormous that must be given of antivenoms. Or, as said, non-African antivenoms are sourced and used which do not really help against African snakes. I learned from the internet that since a few years, Kenyan scientists are developing their own anti-snake venom. They're catching snakes all over Kenya to collect the venoms and produce antivenom. I'm not sure whether this is intended to be one or several, so one for all or several for distinct snakes. There is another group, the Antivenom 8 of the Global Snakebite Initiative, which is trying to develop a new Pan-African antivenom, a polyvalent antivenom against all the medically most important snakes in sub-Saharan Africa. But they're also still developing it. Both the Kenyan approach and the Antivenom 8 approach will take some time, unfortunately. So remember for snake bites. The good thing is even highly poisonous snakes can give dry bites without venom injection. It's not automatic that the venom is injected. The snakes has some playground for decision, so to say. There may be a dry bite, but most bites actually are with venom. Antivenom must be given as per specific product information leaflet, preferably as an infusion over 30 to 60 minutes or as a bolus for neurotoxic bites because you don't have that much time until the paralysis reaches the respiratory muscles. Some things you must remember. For neurotoxic bites, the antivenom will not prevent the progression of paralysis, but will shorten the time and speed up recovery. Patients can still die after antivenom injection without life support. So you cannot take the patient off from the mechanical ventilator after you injected antivenom. For cytotoxic bites, the antivenom will prevent further increase or extension of the tissue damage. It cannot reverse the damage that has already happened. For hemotoxic bites, boomslang and saw-scaled viper, the antivenom will usually stop the bleeding within 15 to 30 minutes and completely restore the coagulation within like 6 hours. But the antivenoms are made from horses. So horses are injected with the snake venom. They make antibodies, and these are harvested from the horse, from the blood of the horse, and given to the human snakebite victims. So you can expect anaphylactic, pyrogenic fever, and delayed serum sickness symptoms. Be prepared to treat these. If you, in some countries, there is a rule, if you give antivenom, have a fully prepared injection of adrenaline lying on the side beside you in case there is a severe allergy. And I would really, really recommend that everybody who might have to treat a snake bite should get the guidelines for prevention, diagnosis, and management of snake bite and venoming in Kenya. It's free to download as a PDF. There you have much more information than I can possibly give here. There are decision trees, there are flow charts, there are pictures of the snakes, more than mine, and maps of their occurrence in Kenya. Because, well, there are very few snakes that live really all over Kenya, in the dry area, in Masai Mara, on the coast. So this is really, really helpful, this booklet or brochure, whatever you would call this. This is a working link, that's why it's blue, so you can easily access it for download if you don't have it already. Well, and the Global Health Action Network, Health Action International, has produced for Kenya posters, for instance, for villages about first aid for snakebite with the do's and don'ts. It comes in English and it comes in Swahili. So these are also very helpful. The Health Action International was so kind as to give me permission to use and promote these posters, which I really like. Easy to understand, even if somebody should not be able to read, but the pictures are also very telling, I think. Okay, so much on nature striking back. Again, here are the important contact details for Kenya. I would like to remind you, like in the other sessions, that it would be very nice and also good for you to join the BioSafe Use Ambassador Facebook group, because this is an exchange platform where you can discuss, for instance, your snakebite experiences or heat stroke experiences. So BioSafe Use Ambassador group on Facebook. And with this, I hand back to Thea, not without saying asante sana for your interest and your patience with me. It has been for me a real pleasure to give these presentations and also to prepare them. I learned and refreshed a lot. So from my point of view, this was a great exercise. I do not want to influence your Mentimeter, but I was very happy with the whole thing. And many thanks to Dorothy and also to Jayesh Pandit for making this possible. And now really to Thea.
Okay, mute yourself. Yes.
Bitte?
Mute. You must have mute.
Bist du nicht auf Mute?
Okay, perfect. So as mentioned at the beginning, we would really appreciate your feedback. So again, here is the QR code as well as the link. You can just go to menti.com and use the code below seen here, or go on the link which I had posted in the chat session previously. And now I will go and share our live polling session. Give me a second. Okay, visible? Yes. All right. So now, if you have connected to Menti, you can also see on the top menti.com and then the code 3616815. You enter that. And then on your phone or on your computer, whichever mobile device you're using, you can vote and we will see the results changing live. So I will leave around 2-3 minutes for the first question, which is, how did you like the training? There are 3 statements which you can evaluate on. So the first is the training content was informative, and you can either say you strongly disagree or you strongly agree, which is a 5 for strongly agree, and strongly disagree would be a 1. The second is the training content was relevant to my profession, and the third statement is the training content was well presented. So yes, please vote ahead. We'll leave a few minutes for this, and then we will go on to the next question.
So let me chime in during this time.
Yeah.
There were a few questions. I'm not aware about a specific treatment of a peripheral neuropathy after snake bite, I must admit. But the role of stone or black stone in snake bite is very simple to be described. There is no role for that. I guess the idea is, I hope the idea is at least not something magical, but a capillary effect to extract the poison from the wound. But if you look at the length of the teeth of a puff adder, you immediately understand there is no way of extracting it from that deep. Okay, so these questions are answered. Because the idea as such is looks convincing. Oh, yeah, there was a question by Thea, why these small suction devices are not successful in snake bites. It's not possible neither by mouth, by sucking with your mouth, nor with such a sucking device to get a realistic amount of venom out of the injection channels of the snake. So they don't work. I had one with me in Namibia, but that was more than 25 years ago, and I beg for pardon. Pardon?
Okay, thank you, Thea. I don't know whether you're ready to run the next question. But as you're getting ready to run the next question, there have been a number of requests for the presentation. So we are working with the ICT so that we can be able to load these presentations. If you go to our CAIRnew website, you'll see there's a tab there for webinars. In that tab, now you have different series. There you see the COVID quality healthcare media conferences. So we are going to add this series of webinars to, as I said, as a pesticide toxicology, as the whole set of the 4 sessions. And we are thankful that Dr. Stephens is going to also provide the slides. So we'll be able to provide this as well. And we will see if it is possible to, within the same platform.
All right, so we have around 50 votes for the first question. It's going up, so I will just leave a few more seconds for those who maybe took a little bit longer to connect. But then soon, in a minute or two, we will go over to the next question. So just leaving you some more seconds to vote, and then we will continue. I am posting again the link to the Menti session for those who have missed it the first time.
Click on the link and then this code.
Okay. Yeah, just click on the link and then put the slider where you want it to be, and then don't forget to press submit, because that's also required to submit your vote. Right, more coming in. In the meantime, we will check again the Q&A session.
Da muss schon zurück zur Präsentation. Okay. Yes. Oh, there are more questions in now.
More questions.
Please explain the pathophysiology of snakebite. I had hoped I had done this. There is an inhibition of coagulation from the hematotoxic snakes by altering or by destroying coagulation factors. There is cytotoxicity, destroying first cells and then the whole tissue area, resulting in necrosis and gangrena. And there is paralysis from the mambas and the Egyptian cobra, which results in a peripheral respiratory failure as the critical endpoint. Another sign besides the ptosis, the drooping eyelids, and the inability to push out the tongue is that when you lift the patient, well, he's seems to be completely without muscles. So the head falls back if you have him on both arms, and the legs just hang from your arm. So it's very clear to see this paralysis.
Just quickly jumping in here. So while Dr. Wilfried Steffens is answering the questions, I just jumped to the next slide. So you will probably see on your device that we move to the next one. So you can just continue. And here now the question is, which part of the training did you like best? So these are the 4 sessions that we had. Poisoning, symptoms and treatment. We had exposure reduction in the second session. Now today, heat stroke and snakebite, and a little bit on Amitraz. And the very first session was general introduction to the crop protection topic. So I see you're already voting, and then handing back to Dr. Wilfried for more Q&A.
Robbie Warhol, can you be more specific? I don't fully understand what you mean by "Hi, doctor, I have a quiz." Well, actually, Carlos, it will take quite a time to collect venom from snakes. But what I was speaking about was Kenya. Still, you have a lot of snakes. I think you don't need an antivenom for all snakes that have, well, a toxic venom, because you only have to deal with the very highly toxic snakes, and the number of these is roughly around 10 or a dozen, so that should be feasible. In principle, you would first need an epidemiology of what snakes are biting people. For instance, do we really know how many bites from wine snakes or tree snakes are there in Kenya? Probably not. Hillary, interesting question. Someone was bitten by a honey badger and the patient, despite him being hospitalized. Does such an animal have antivenom? Not to my knowledge. There are mammals that have venom. We have a kind of mice here in Germany that eat insects and worms. They actually have a venom. But I'd never heard about a venom in a honey badger. What I can imagine, one of the problems with animal bites, whether it's a tarantula, so a large spider, or whether it's a dog, they don't keep their teeth and biting organs in spiders very clean. So it's very easy to get a really severe bacterial infection from that. You used black stone, it worked miracles. Yeah, it should not be used. Well, there simply is nothing to it. Then maybe it wasn't a poisonous snake bite, or it was a dry bite, and then, well, probably it would have been okay without the black stone too. How poisonous are wall geckos? To my knowledge, not at all. wash the bitten area. What's with jig solution? I have no idea what jig solution might be. Sorry. In case of severe bleeding from snake bite, is vitamin K recommended? No, not really, because vitamin K takes hours or days to stop the bleeding. If there is really severe bleeding from a snake bite and you don't have an antivenom, you should rather use fresh frozen plasma or factor concentrates or simply transfusions to try and stop the bleeding.
So please, if you, because I see some of you putting messages in the chat on the voting, please use the Mentimeter. So I posted again the link, just click on there and then you can directly submit your vote. Thank you.
Well, somebody has a brother bitten by a snake the day before yesterday. He was put an antibiotic and I think steroid. No paracetamol probably. Without antivenom, will he be at future risk? No. If he survives, there will be no, and probably he will be survive. Otherwise, he would have been treated differently. The Q&A were moving, sorry. He will not be at future risk. Antivenom for spider bites, I'm not aware of that for Kenya. There are very few antivenoms for spiders and scorpions, actually. Can you kill the snake, carry it to hospital with the patient? As said, that's not a good idea. Trying to kill a snake, you may be bitten yourself. You can take a photo with your mobile phone, if you have one with you, of the snake and show it to the doctor, and he can, if he doesn't know, he can compare it to this government advice where there are nice photos. Role of tourniquet in snake bites, no. This does not really help. If it will increase tissue destruction, because the poison, the venom stays where it is and is active all the time in the same area, so the necrosis will become larger. For other bites, it doesn't really help either. So a tourniquet is not recommended for neurotoxic bites, so mambas and Egyptian cobra. This pressure immobilization is recommended, which clearly is not a tourniquet, but only with the strength you would bandage a twisted ankle. Hypochlorite solution. Well, you can try to wash the skin, but I'm very doubtful that it would help, because the poison is deep in the tissue, and this is a place where you don't want hypochlorite solution that deeply in the muscles or wherever it went, the bite went. On the skin, I wouldn't object, but not more.
Okay, just quickly jumping in here, we moved on to the next question. So the question is, what more would you have liked to hear about pesticide poisoning in either the Kenyan, African, or global context? So were there any topics that were missing from your side? I just see now, for example, organophosphate poisoning. I understand that probably not all of you attended all of the 4 sessions. So this also going to remind that on the CAIRnew YouTube channel, you will find our first 3 sessions if you did not have the chance to attend these. And the 3rd session, which was last week, this also covered organophosphate poisonings. But I think that Dorothy will add to this at the end of the session again. Yeah, this question is just open question, so type in whatever you like and submit. Thanks.
And Hillary asks, what's the reason behind giving bolus infusion to the patient that who has a neurotoxic poisoning? As said, you don't have that much time. the patient can die within a few hours. The 20 minutes for a black mamba bite is, well, overdoing it. It's not that bad, but it's not more than hours. So if the patient takes like 2 hours to a hospital with the antivenom, you should give as much as possible and quickly. It's different with the hemotoxic and the cytotoxic bites. There you have more time and can do an infusion. Well, Sylvester, are there institutions providing antivenom in Kenya? Frankly, I don't know. This may be a question maybe to Dorothy, whether she knows. I have a list of antivenom suppliers as of 2019, but I have learned that many of them all over the world are not producing it anymore. Unfortunately, snake bites are not big business. So, yeah, some of the antivenom producers drop off.
Okay, thank you, Dr. Stephens. There's one other question there about a frog bite.
Oh, interesting question, Paul. Someone got a bite from a frog in Kenya. Today I heard over the radio that he developed some lesions that are now debilitating. Are frog bites common, and are there antivenoms for frog bites? Last question, definitely no. I'm not aware that the bite of a frog is actually poisonous, but there are many of these amphibians that have relatively strong toxins on the skin. If you think of the very colorful South American tree frogs, they're used as poison on arrows to kill deer or whatever animals they shoot with it. The large agar toads are quite poisonous, and some of the frogs, for instance, in the American Southwest, have a secret that is hallucinogenic. I wonder whoever got the idea of licking a toad, but somebody obviously did and had a trip. So the skin is toxic, and maybe if there was skin secret in the wound, maybe something happened. But usually frog bites, they are not common, and definitely there are no antivenoms.
All right, before moving up to the last question, I would like to give Jayesh the opportunity to ask something, which he requested. So please, Jayesh, address your question.
Thank you, Thea. This is more to all of us, especially the panelists, but more
Are you already a panelist? Yes, you should.
Yeah,
and you're not
me?
on mute, so.
Can you hear me?
See your microphone moving, but unfortunately we cannot hear you.
Can you hear me now?
So maybe if you can instead type your question, then I can read it out.
We can hear Jayesh.
Yeah. So Dorothy, I'm
Yes,
actually
In the
reaching
meantime,
out to
just moving to the next
Thea.
and last question is there anything else you would like to let us know? So any comments, recommendations, whatever.
Sorry, Thea.
Oh,
Thea.
I cannot hear you. That's right.
Thea, we can.
Neither with feet.
We can hear.
Now we are. Wait, maybe I will turn on the audio, and then we might have an echo, but. Okay, Jayesh, please go again.
Yeah, can you hear me now, Thea?
Yes, very faintly, but I can hear you.
Okay, super. So mine's more of a question to bring this 4 webinar series to a close, and I'm actually reaching out to Dorothy and our colleagues from AAK or CropLife or PCPB, how is it possible for us to have a national poison information center, to have a poison information center that also talks about pesticides or pesticidovigilance, as I try and call it. And I don't know if Wilfred, you have, or Vijay, you have any experience out of this. How can we make a vibrant, active, well-known poison information center for Kenya? You know, it's trying to really bring everyone together.
The question is first to Dorothy.
Thank you very much. I appreciate that question. We part of starting this session was actually reaching out to address the need for having a national poison information center, or at least revamping and making it more accessible and having the services easily advertised, and we can be able to know where we can go for as a point of call. So that is something that we are still having at a preliminary stage, and we are in talks with the Agrochemical Association of Kenya, and we're also reaching out to various industry players like the Bayer CropLife and any other partners who are handling pesticides, and we're looking at a whole range of chemicals, identifying them slowly so that we can build this. So that is something that I can say this is a first step towards having that national poison information center. I think that is, I hope that answers your question.
Yeah, no, sure. Thank you. I just wish we can get everyone on board, PCPB, CropLife, everyone, and really make this out there to the public. I believe public will really benefit.
Okay, thank you. Tia, are you done? We are getting to 3:30. We are to be.
Yes, the voting is done. So thanks a lot for all your feedback. If you would like to reach out like in the future, I think you can go through Dorothy or CAIRnew, and they would be happy to provide contact details to us if you have any questions. And yeah, with this, just quickly handing over to Dr. Wilfried for final remarks, and then back to CAIRnew team. Thanks.
I'm not hearing Dr. Wilfred. Dr. Wilfred, did you have any final comments, or we could wind up?
Wait, we will. His microphone seems to be acting up, so we will just use my computer.
Okay. Then we do it this way. Sorry, somehow complicated again. Well, asante sana to all for all of your interest, for the discussions, interesting, even challenging for me, which is very good. The whole thing has really been a pleasure for me. And well, regarding Poison Control Center, I've never worked in one, but I have many contacts to poison control centers in many countries. So if I can be of help, I would happily do that. Yeah, I hope this has been useful for you, and thank you very much. Maybe we meet again. Goodbye.
Thank you very much again for being our guest for this whole month, taking us through this series. Now, for those who have asked about the presentation, we intend to load them here, the CAIRnew website, and this is how you're going to be able to access them. So we'll ask for your patience. You give us a week. We work with the ICT department. So you will be logging to the CAIRnew website, and then you get here to the webinars. When you access this link, under webinars, you will be able to see, we'll put there the pesticide toxicology series, and we'll be able to have both the link to the videos and the PowerPoint presentation. And for future presenters who would be willing to share their presentations, you'll be able to access them from this same center. So Then with regards to the questions about CPDs, at least I want to thank a few who have volunteered to assist us with that aspect. We are going to be able to get a team together to help us disseminate the CPDs. And so you should just give us about 2 weeks or so to be able to resolve that. I think that's most of the questions which are related to CPD, but otherwise we continue to have the events loaded on the portal so that you can be able to see them. And we hope that you have actually learned quite a bit from these sessions and that you can be able to, it can help you advance your practice. We want to thank you again for giving us your time and your ear, and we hope that you will join us for future sessions. Tomorrow we will be having the fluid and drug therapy management, and then we will have the advances in diagnostic pediatric TB. Now, for those who ask, the TB series is listed just as either adult TB, pediatric TB. So that's how you'll find them listed in the portal. So thank you very much. And thank you so much for our team from Bayer for your time this month. Thank you so much for the Crop Life team. And we are hoping that we will soon be able to announce how you'll be able to reach the Poison Information Center. Thank you and good afternoon.